Good morning. My name is Elizabeth Victor with the New England QIN-QIO, and I will be your moderator for today's webinar. Session 5, How to Get an A on your report card, Prevention and Management of C. difficile and Other Healthcare-Associated Infections. Before we get started, I have a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. You can pose a question in the chat box on the bottom left on your screen. Please make sure to send questions to all attendees. And now I'd like to introduce Carrie Barton with the Massachusetts Department of Health. Carrie?
Good morning. It's my pleasure to introduce Dr. Shira Doron and Dr. Beaulac. Shira Doron is a physician in the Division of Infectious Diseases at Tufts Medical Center. She has been the physician head of the Antimicrobial Stewardship Program there since 2005 and is also the Associate Hospital Epidemiologist. On a national level, Dr. Doron serves on the Society for Healthcare Epidemiology of America Antimicrobial Stewardship Subcommittee and the Infectious Disease Society of America Antibiotic Stewardship and ID Leadership Working Group. Here in Massachusetts, Dr. Doron has been involved in several statewide initiatives to improve the care of patients with suspected or confirmed infections. Dr. Doron has numerous publications related to antimicrobial resistance and stewardship. Kirthana Beaulac is a pharmacist who trained at Massachusetts College of Pharmacy, completing postdoctoral training in infectious diseases at Hartford Hospital. She is the pharmacist head of the Antimicrobial Stewardship Program at Tufts Medical Center, as well as the infectious diseases pharmacist for the institution. Dr. Beaulac is involved in the Massachusetts Society of Health System Pharmacists, the Council of Boston Teaching Hospitals for Pharmacist Education, and the Society of Infectious Disease Pharmacists. Her research focus is in methods of optimizing antimicrobial use. Thank you, Shira and Kira.
Thank you for that introduction. So, as I mentioned, we're going to speak today a lot about the prevention and management of C. diff as well as other healthcare-associated infections and focusing on how to get an A+ on your report card. And many of you may not even have a report card currently, but a lot of what we're going to talk about today is the fact that, one, a scorecard is coming and what you can do to stay ahead of that. So before we begin, we're just going to do a quick polling question to get a sense of where everybody's at in terms of their antimicrobial stewardship program. So would you mind responding, with regard to antimicrobial stewardship, I feel that my facility either A, has a program in place, B, has a plan to implement a program, or C, has little, if any, program or plan. Again, this is whether or not you currently have an antimicrobial stewardship program either in place, a plan to implement a program, or no program and no plans in the near future. And if you just bear with us for just a moment, those results will be right up. And we can use this information to kind of guide the way our discussion goes throughout the presentation. And our results are that the majority of people, looks like, 35 respondents said that they have a plan in place to implement a program. 19 people said that they already have a program in place, and only a few respondents, only 5, said that they don't have a program in place. So it looks like we're making headway, and it looks like each time we do these webinars, the number of people that answer C is fewer and fewer, so it looks like everybody's really getting on board with these initiatives. So that's great news. So what we're really going to focus on today is the current landscape of tracking and reporting C. diff and other reportable infections, and that's going to be done through NHSN, which is the CDC's database. We're also going to evaluate some antimicrobial stewardship strategies that can be used for preventing C. diff infections. And lastly, we're going to try to identify some interventions to avoid healthcare-associated infections and kind of some strategies around treatment. So the NHSN is the National Healthcare Safety Network. We're going to refer to this as NHSN frequently throughout this presentation, but what the NHSN is that it's a database, it's an infection tracking system that is routinely used by the CDC. Currently it is collecting data from facilities across the United States, primarily acute care facilities, and they collect that information and they feed it back to individual facilities, states, region, and the entire nation to provide us statistics and guidance about what's really happening on the ground in terms of healthcare-acquired or healthcare-associated infections. The goal of this program are to identify any infection prevention problems that may be arising and ideally nip them early in the bud, to benchmark progress of efforts in the area of infection prevention, and lastly, to help drive progress towards inevitable elimination of healthcare-associated infections. Now, as I mentioned, currently it's mandatory that this database be used in the acute care setting, but in the long-term care setting, it's slowly moving in that direction, but not 100% yet. Currently, NHSN reporting is voluntary in the long-term care, for long-term care facilities, and there are a handful of facilities across the state of Massachusetts that are currently reporting data to NHSN, but it's in the pilot phase, and it's expected to become mandatory reporting in the not-too-distant future. We think that the reporting requirements will start with the C. diff measures, but will inevitably include things like MRSA, UTIs, healthcare personnel, influenza vaccination, hand hygiene statistics, gowning and gloving compliance, and then any healthcare personnel exposures. All of those will be reportable metrics in the foreseeable future. As I mentioned, there are currently 62 long-term care facilities in Massachusetts that are enrolled in NHSN, and some of them are entering data into NHSN to provide feedback for benchmarking. And even there's one facility that's entering their staff vaccination data. The DPH, the Massachusetts DPH, currently has a goal to enroll an additional 50 long-term care facilities this year to be able to enter data regarding C. diff. So I've mentioned this is, a giant database, and entering information into this database can be a little bit complicated. So part of what we want to talk about today is how to go about being involved with the NHSN database. So I have a couple links on here, but I'm going to walk through what are the requirements and what is the information that they're looking for. So for every patient that has what they call a lab ID event, or a reportable event, whether it be a multi-drug-resistant organism or C. diff event, they want to validate that it was from an unformed or loose stool that either test positive for C. diff, toxin A or B, or if there was a loose stool that toxin-producing C. diff was cultured or identified via other laboratory means. Now, once we know that the patient does have a positive C. diff, there's a lot of steps that need to be filled out throughout these forms to identify a little bit more about that event. As I mentioned, here's the link to the blank form, but there's also more detailed instructions on exactly how to accurately and completely fill out these forms. Now, there are going to be two pieces to the requirements of submission. So there's the events, these lab events, these positive C. diff events, but as well they're going to want a denominator. They're going to want to know how to normalize this information to your facility, because if you have 5 C. diff events in a quarter, the CDC needs to know how to normalize that if you're a 15-bed nursing home versus a 150-bed long-term acute care hospital. So there's a lot of variability in the way this data can be reported. So an accurate denominator is important, and that could include number of resident admissions, number of resident days, as well as number of admissions of patients that are already on C. diff treatment. And then so, as I mentioned, there's a couple of important pieces in that form that needs to be filled out, but one of the really important things is going to be knowing when the specimen was collected, because inevitably these are negative outcomes that are a consequence of our care. So the I guess outcome that needs to be attributed to somebody. And each of these C. diff events is going to be categorized as either a community onset event, a long-term care facility onset event, or potentially it happens somewhere during the mix of the acute care transfer to the long-term care facility. So essentially somebody has to take responsibility for this. And the best way to figure out who is responsible is based on when the specimen was collected and where the resident was at the time of admission or at the time of specimen collection and in the previous few weeks. So if the specimen was collected less than or equal to 3 calendar days from admission at your facility, then it would be considered community onset. If it was more than 3 days after admission to your facility, so on day 4 or after, then that would be attributed to the long-term care facility. But there's also this new category of acute care transfer to long-term care facility, and that would be, if it happened in a resident that had been in an acute care facility within the prior 4 weeks. And all of these events need to be reported to the NHSN, but then the NHSN will kind of just filter out what's attributable to you and really only hold you accountable for those events. Now, there's a lot of information. The whole process of benchmarking and filling out this database is really complicated. There are a bunch of resources available to you, and I could speak for 3 hours on how to actually input this data, but rather than do that, as you're getting ready to participate in the NHSN, I highly recommend that you visit some of these links. The long-term care facility website for the NHSN is listed here, as well as some specific links for C. diff and MRSA. There are things like training and protocols. They have the blank collection forms along with instructions on how to compile that data, and then some other key terms that would be useful to you as you're submitting that information. Now, I'm going to talk to Shira, who can talk to you about what's going to happen with that information.
So the main benefit to you when you submit information to NHSN is that you get back reports that allow you to benchmark your performance against other facilities. So this is already happening in the acute care setting, and so these are some examples of reports from our hospital. And the TAP report, this is part of the TAP report that you see here, and TAP stands for Targeted Assessment for Prevention. And what the TAP report gives you is here you can see for Tufts Medical Center for a given time period what the number of expected infections was in that time period based on like hospitals. Various characteristics of the hospital, including some risk adjustment. So obviously size, academic medical center, but things like are you a transplant center, are you a trauma center, those all go into the mix. And so how many infections, C. diff infections, was your hospital expected to have? And here it was a little bit over 63. And that's compared to the number of actual infections that we had in that time period, which was 76. And so what you get, and this is the standardized infection ratio, and the SIRs exist for all of the infections reported through the CDC, and that is a risk-adjusted number that tells you how you compare to your goal, essentially. And you always want your number to be less than 1, because an SIR of 1 would mean that you're doing about what's expected.
Now, the default goal in your TAP report is the Health and Human Services goal, which is to improve by 30% every year, but you can set your own institutional goals. You also get this type of printout, and you can see, using this part of the report, all of the facilities in Massachusetts. And so, again, these are acute care facilities, and presumably the same type of report will exist for long-term care facilities in the future. And every hospital is given its own secret code, so you know which one of those hospital codes is your facility. And then your hospital's ranking, with number 1 being the worst. Again, you can see the number of events you are supposed to have, and the cumulative attributable difference, or the number of infections needed to avoid to be a goal. So if the hospital number 8, which was the worst hospital, had 123 fewer C. diff infections in this example, they would have been at an SIR that was that goal. And in addition, it will show you whether your numbers are actually statistically significantly different than what's expected or not. So you might have an SIR that's greater than 1, but if your compared to predicted is listed as same, then yes, you're higher than you should be, but not in a statistically significant way, which can be somewhat reassuring. So why would anybody do this? As I said, it allows you to benchmark your results with those of other facilities. In turn, what do you do with that? It forces you to evaluate your current practice and to generate action plans. And as mentioned, this will eventually be required, and the more historical data you have, the better ability you will have to use the system and accurately risk adjust. So that brings us to polling question number 2. And so we ask you to think about the following question and to enter your response, checking all that apply in the polling section on the right. You may need to click on the down arrow next to the word polling on the right side of the screen to see the polling questions. And the question is as follows. The CDC currently collects information about C. difficile, MRSA, and device-related infection rates from acute care hospitals through the NHSN and benchmark performance. And then, Lacey, if you could open the polling question, please. CDI data reporting for long-term care is currently in a voluntary pilot phase. Which of the following elements do you think it would be feasible for your facility to report to the CDC database? Again, check all that apply. Do you think it's feasible in your facility to report C. diff rates, UTI rates, hand hygiene compliance rates, gowning and gloving compliance rates, MRSA acquisition rates, healthcare personnel influenza vaccination, or none of these? And obviously they all have their challenges. We talked about how C. difficile rates are to be done essentially using lab ID, so the lab sending information to the CDC with the facility collecting denominator data. UTI rates, are you collecting any data on that right now? Are you able to do that? Hand hygiene, are you observing hand hygiene compliance in your facility? Do you know how you might do that? Gowning and gloving, MRSA acquisition. Okay, so let's take a look. So we have 2 facilities that said that they don't feel that it's feasible to submit any of these, and we have a good number of facilities that thought that UTI rates and healthcare personnel influenza rates would be easy to collect, and MRSA acquisition as well. The largest number said C. diff rates, so that's great. So people are thinking about that because that's coming soon. And it sounds like some difficulty in thinking about hand hygiene compliance and gowning and gloving compliance. So that's really useful information for us and for the Department of Public Health and the CDC going forward, and we'll be keeping that data and using it.
All right, so next I'm going to talk a little bit about, C. diff as an infection. What can we do to prevent and manage it? It's spread over kind of throughout your facility. So patients develop C. diff kind of
because of two factors. And for the most part, both factors need to be present in order for a patient to develop C. diff. There needs to be some sort of susceptibility within the host, so your resident needs to be in some way weakened. Most commonly, this is through antibiotic exposure. Taking antibiotics kills your gut flora, and it makes the host more susceptible to getting C. diff. And then, on top of it, they need to be exposed to the organism, and its exposure route is through the fecal-oral route. They need to have some, exposure to C. diff, and then eventually it would, make it to their mouth and then colonize their gut and then cause infection. So here we have like a graphic that explains kind of the time course of how antibiotics actually cause C. diff. So remember that all human beings have healthy flora, healthy normal flora living in their gut that keeps that is regulated and kind of maintains a steady state that's a nice community with checks and balances in it. Now, when a resident takes antibiotics, that you see that the flora gets disrupted. So that red line drops dramatically because it really is messing with your gut's normal flora. And with that, you see the green line, which is the C. diff risk, increases dramatically in this setting of utter chaos within your gut. That risk persists for long after the antibiotic course is completed because, as you see, it takes a little while for the disrupted flora to regrow and repopulate and maintain a nice balance again. And the duration that it takes for that flora to restore is the duration at which the patient is at risk for C. diff. Now, we know that antibiotics are very closely linked with C. diff, and using less antibiotics is consistently associated with less C. diff. Here we have a nice population-based study out of the UK that showed that, they had mandatory C. diff reporting starting in the early 2000s, and their rates were pretty high, but once they started implementing some hospital restrictions on fluoroquinolones and cephalosporins, two classes of drugs that we know that are highly linked with C. diff. Once they started restricting some of those, they saw some significant impact on their C. diff rates going forward. So they were able to mitigate some of their C. diff risk just by using less fluoroquinolones and cephalosporins. And so to kind of piggyback on that theory, not all antibiotics bear the same risk of causing C. diff. So antibiotics that have activity against obligate anaerobes are going to impact the gut flora more and increase the risk of C. diff more. So we think about drugs like clindamycin, fluoroquinolones, and cephalosporins being your higher risk antibiotics for C. diff. And then there's some drugs that are considered much lower risk for causing C. diff. Things like tetracyclines, sulfas like Bactrim, and even to a certain extent penicillins that have less activity on disrupting your gut flora. Those are going to have a lower risk of predisposing our residents to C. diff. So whenever you're just choosing an antibiotic for your patient and you have multiple to choose from, trying to choose from the lower risk category may provide some benefit to the resident in terms of C. diff protection. So it's not only the use of systemic antibiotic that increases risk of C. diff, but even C. diff treatment increases risk of later C. diff. Here we have a model that looked at what is the impact of oral vancomycin, which is oral vancomycin is only used for the treatment of C. diff. But when you give oral vancomycin, it not only decreases the colony count of bacteria, so the number of bacteria that's in the gut, but it also decreases the diversity. So there's not only a big quantity of bacteria in the gut, but there's all different kinds, thousands upon thousands of different kinds of bacteria in the gut. And the diversity also gets blunted when patients are exposed to oral vancomycin. And what was really interesting out of this study is that, even getting a 2-week course of vancomycin significantly decreases the number of bacteria and diversity of bacteria at 2 weeks, 6 weeks, and even at 14 and 22 weeks, the subjects that got vancomycin were still not back to normal. It can take a very long time for gut flora to repopulate. And when you look at the bottom figure, you see, what a normal untreated gut looks like. There's a lot of Bacteroides in there and the Firmicutes. And when you give vanco, all of that gets wiped out, and it takes weeks upon weeks upon weeks to see some meaningful recovery. And even then, the Firmicutes comes back kind of sooner, and the Bacteroides, the normal healthy Bacteroides, takes a long time to recover. So just recognize that even if you are misclassified, you're not really certain if a patient has C. diff, but you want to just treat them anyway because you think, just in case it's probably not going to harm them. Recognize that treating C. diff inappropriately with oral vancomycin and flagyl can have significant impact of risk on C. diff later. There are a few more risk factors that you should think about for C. diff. There's advanced age, which pretty much represents the entire population here. If patients have had intestinal surgery or obesity, patients who have IBD are at higher risk of C. diff. If they've had chemo or stem cell transplants, they're also at higher risk of C. diff because those therapies do a lot of the same things that antibiotics do, because chemotherapy not only kills human cells that are, bad tumor cells, but they also kill gut flora as well. And lastly, gastric acid suppression, so proton pump inhibitors or PPIs and H2 blockers or H2RAs also have been very closely linked with risk of C. diff. This one study found that patients who were on a PPI, and I'm sure many of your patients are on a PPI kind of for some unknown nebulous reason, being on a PPI not only increased the patient's risk of C. diff significantly by almost 6 times, but if they did have C. diff, they were much more likely to have a severe C. diff infection rather than mild to moderate infection. And they were much more likely to have a complicated infection than people who were not on a PPI. So being on a PPI not only predisposes patients to developing C. diff, but if they do develop C. diff, it's more likely to be a worse case of C. diff. And so as we're implementing all of these antimicrobial stewardship interventions, it's really useful to think about, other things that you can do that have the same mission, like PPI stewardship. A lot of the concepts still apply, that we're trying to do what we can to mitigate risk of C. diff, and we're just trying to improve drug use. So here we have an example of a hospital that noticed that they were using a lot of PPIs, and at first they had this automated alert that decreased PPI use a little bit, but then they implemented a second intervention that linked the PPI stewardship with their antimicrobial stewardship, and they found a much more dramatic reduction in their PPI use and a much better outcome. They weren't able to quantify improvements in their C. diff rates because they had really low C. diff rates to begin with, but it's important to recognize that all of these interventions have similar outcomes, so it's kind of a good strategy to bundle them from the outset, that we're all kind of working together on the same ideas. So being able to improve PPI use, you can also work that into your antimicrobial stewardship program.
So aside from medications like antibiotics and proton pump inhibitors, other factors that increase the risk of CDI include environmental ones. So hand hygiene is really important. As we talked about the double whammy, having exposure to C. diff in a susceptible host, hand hygiene, or hands, are really one of the main sources of transmission. Healthcare workers who take care of a patient with C. diff or are in a room with a patient with C. diff, spores get on the hands. and then that healthcare worker comes in contact with a susceptible patient. Room cleaning, therefore, is really important. C. diff in the environment takes the form of a spore. Spores are hardy. They're hard to kill. They don't dry out quickly, and they can stay in the environment for a really long time. And so room cleaning needs to be a very meticulous part of C. diff prevention. And the usual quaternary ammonium compounds that are used as disinfectants in healthcare settings do not work against C. diff. So bleach cleaning is really the standard. Interestingly, it seems that not only is a prior patient with C. diff in the same room a risk factor for subsequent development of C. diff by someone in that room, but if the prior patient in the room received antibiotics, even if that patient didn't have C. diff, the person in that room is at risk for C. diff. So here's a study that came out quite recently in JAMA Internal Medicine showing the risk of C. diff infection according to receipt of antibiotics by the prior bed occupant. And you can see that the chances of C. diff-free survival of the patient in that room are lower if there were antibiotics given to the prior bed occupant. So if we needed more reasons for antibiotic stewardship, this is yet another one. During the course of these webinars, and this is our fifth one, we've had many questions about probiotics, and we promised that we would get to this topic in some more detail. Probiotics, according to standard definitions, are living microorganisms which, upon ingestion in certain numbers, exert health benefits beyond inherent general nutrition. So something you ingest that makes you healthier and that is alive, essentially. The key question that we are always asked, can probiotics help prevent C. diff from developing in patients taking antibiotics? And the answer is not very clear-cut. So the best data that we have comes from a Cochrane systematic review in 2013 that looked at 1,871 studies. Of those studies, only 31 met criteria to be included. The rest were not of good enough quality. Those 31 studies included 4,492 subjects. And in those studies, overall, probiotics reduced the risk of C. diff-associated diarrhea by 64%. 2% in the probiotic group versus 5.5% in the placebo or no treatment groups. So some of the studies did have a placebo and some of them just no treatment. So those were the differences. Now, the authors of the Cochrane systematic review came to the following conclusion. Based on this systematic review and a meta-analysis of 23 randomized controlled trials, including 4,213 patients, moderate quality evidence suggests that probiotics are both safe and effective for preventing C. diff-associated diarrhea. But what I will tell you is that each probiotic strain behaves differently. So one cannot extrapolate results from a study using one strain to the efficacy of another. So this is probably not as clear-cut as what you would like to hear, but you can't take the Cochrane systematic review or a meta-analysis that says we saw good results with probiotics and purchase any probiotic off the shelf and say this is going to be good for C. diff. Every strain is different, just as every antibiotic is different. Just as we don't say antibiotics treat C. diff, there are in fact only 3 antibiotics on the market that do, we can't say that probiotics prevent C. diff, and so that makes it really, really difficult in a clinical setting to know what to do. The most well-studied probiotics are Lactobacillus GG, which is found in essentially 2 products on the market in the United States. One is called Shira, and one is the yogurt called Danimals, which is marketed to children. And Saccharomyces boulardii, which you can find in a number of commercially available products, including Florastor. But adverse events have been seen with both of these products and all probiotics, and those include bacteremia, endocarditis, and liver abscess. I personally have seen quite a few cases of Saccharomyces boulardii infection, including in long-term care patients. And we have seen infections caused by lactobacillus in patients taking lactobacillus GG. Particularly concerning are infections that we've seen in patients who have venous access catheters, IVs, or central lines, where the capsules might be opened by the healthcare provider, by the nurse, in order to deliver the powder inside the capsules either by tube feeds or in order to dissolve it in a drink or applesauce. That powder easily gets onto healthcare worker hands or gloves, and then if the vasculature is manipulated, we've seen bacteremia as a result. Changing gears a little bit, I want to talk about the diagnosis of C. diff, and I want to give a big warning here. Increasingly, laboratories are using PCR testing for the presence of C. diff. And so this is a C. diff testing algorithm that's becoming more and more typical. On the left, you see a negative test. This is a combined test that looks for both antigen and toxin. And in 77% of samples sent, the result will be negative for both of these. And that is a clear-cut negative C. diff. In the middle, you see a test which is positive for both the antigen and the toxin, and that ends up being about 12% of samples, and those are clear-cut patients that need to be treated. They have both the antigen and the toxin, which we know is the aspect of the C. diff that causes disease, and so about 89% of samples sent will either be clearly negative or clearly positive. But 11% of samples will be positive for the antigen, meaning the organism is present, but negative for the toxin, which is what causes disease. And in that situation, there's a decision that needs to be made, and as I mentioned, increasingly those patients' samples are being sent for PCR testing. Now, the big caveat here is that patients who have positive PCRs only without a positive toxin test may have colonization rather than infection. But in clinical practice, the majority of those patients currently are being treated. Those patients are also being considered lab ID events, and those numbers are being sent to the NHSN, and those patients are considered, for reporting purposes, to have C. diff. Now, as with other situations where there is colonization rather than infection, those patients do not warrant treatment, and treatment is harmful in those patients. And Shira went over why treatment for C. diff would be harmful in those patients, because oral vancomycin or oral metronidazole, or oral fidaxomicin, those are the three approved antibiotics for C. diff, all of those are going to impact the gut flora and increase the risk of future episodes of real C. diff. So we recommend treatment only if the patient has true diarrhea. That means a stool that's loose and the shape conforms to the shape of the container. That means clinically significant diarrhea, more than 3 loose stools in 24 hours, unless the patient has ileus. And in rare situations, and I'm sure you all have seen this, the patient doesn't have diarrhea, but they have abdominal pain, they have distension, they have fever, leukocytosis, etc., and they may have true C. diff, but that is the minority of cases. Now, it's important that diarrhea be a change from baseline. Many of our patients have chronic loose stools for a variety of reasons, and if that is their baseline, that is not considered symptomatic C. diff. And it's important that diarrhea not be able to be explained by other causes, not by laxatives, tube feeds, lactose, for example. And what we're seeing a lot of is patients who are constipated, given an aggressive bowel regimen, then they have a loose stool. That stool is sent for C. diff testing. That stool is then PCR positive in a setting where they had an equivocal test, and that patient then gets labeled as having C. diff, reported to the NHSN and treated, when in fact the loose stool was only due to the aggressive bowel regimen. So remember, antibiotics for C. diff can increase the risk of C. diff, and do not do tests of cure. PCR tests detect DNA of organisms, whether those organisms are dead or alive. PCR in patients with C. diff can remain positive indefinitely, and so there is no utility to testing for C. diff after making a diagnosis of C. diff. So that brings us to polling question Number 3, again, you may need to open the polling section on the right-hand side of your screen, and the polls are open. Which of the following strategies, check all that apply, is your facility using to minimize the risk of C. diff acquisition in your residence? So let us know, are you using antimicrobial stewardship? Are you using enhanced cleaning of rooms housing residents with C. diff? Maybe you're using bleach in those rooms. Maybe you're having supervisors monitor cleaning. Enhanced cleaning of beds and mattresses used by residents with C. diff. Contact precautions for residents with C. diff. Private rooms. Clothing has closed. We're going to see in a minute. Bedside commodes for residents with C. diff. Residents with C. diff use gowns and gloves when leaving their rooms. Routine use of probiotics in all or certain residents. Prophylaxis against C. diff using oral Venco for certain residents, like those with a history of C. diff. Prolonged C. diff treatment regimen, or none of these. Prolonged regimens more than 10 days are used by some with tapers. Those are recommended sort of loosely by some of the guidelines. There's not a lot of clarity on how to do that. So we'll see in a moment what people are using, and this will, again, be very helpful in us moving forward in terms of developing standardized protocols and understanding the environment out there when it comes to C. diff. We're told that some facilities use bedside commodes in residents with C. diff. There's a lot of questions about how long that should continue. Should a patient with treated C. diff who's no longer symptomatic continue to use the bedside commode, or can they share a bathroom with a roommate at some certain point, knowing that C. diff spores are shed for long periods of time, even in patients who are no longer symptomatic, and for unknown periods of time. Yeah, so we're not seeing the results, so I think we'll go ahead and move ahead, and maybe, there we go. Okay. So interestingly, only one facility is using a prophylaxis, and we like that answer because, again, antibiotics against C. diff do interfere with the microflora and increase the risk of C. diff. Only one facility is using prolonged treatment, and we think that's probably a good idea to avoid as well. A few facilities are having residents use gowns and gloves when they leave the room. Some facilities are using probiotics, but the largest number are using antimicrobial stewardship, which is great. Enhanced cleaning, which is terrific. Cleaning of beds and mattresses, that's great. That's an important place to be focusing efforts and contact precautions. Bedside commodes are used by a fair amount as well.
All right, so next we're going to talk a little bit, we talked a lot about C. diff, but there's a few other healthcare-associated infections that will inevitably be part of your report card. So we want to talk a little bit about what you can do for prevention and management of those. So first I'm going to talk about UTIs because that's, always a big thing on everyone's mind about what can we do to minimize our UTIs. The goals of NHSN are to eventually monitor UTI rates with a couple of different, objectives. They want to be able to calculate rates of UTIs among residents in a facility, and they're going to be broken down into non-catheter associated UTIs versus catheter associated UTIs. And then they want to identify which residents get UTIs. So you have to identify, of your population who actually have UTI, and they're going to kind of further drill down into which organisms are causing UTIs in your facility. And all of this is going to be based on some of the McGear's criteria that we talked about a few webinars ago, that they're really great for surveillance for things like this, but not quite as useful for clinical diagnostics. And they also are going to want to monitor some of your antibiotic use for UTIs. And then lastly, to assess the impact of your efforts in preventing UTIs over time. And here I have the example of the form. Again, just like the C. diff form, inputting data into the long-term care facility side of the NHSN database is going to be a little bit challenging at first and labor-intensive. As you see, this is kind of a complicated form. but I just wanted to give you a sense of what are the types of data elements that you'll be looking for. And it's also going to, interestingly enough, there are some patients without symptoms that are going to be included in this UTI surveillance tool. So patients who have asymptomatic bacteriuria, that means bacteria in their urine but no symptoms, those patients would not be included. But patients who have asymptomatic bacteremic UTI will be counted. So those are patients who have bacteria in their blood and in their urine that are matching, but no signs or symptoms that are localizing to the urinary tract. But it's really important that the organism needs to be growing in the patient's blood as well. And it doesn't really matter whether or not the patient has a catheter. Those patients will be included in your statistics. So, as I mentioned, they really want to look only at symptomatic patients, not necessarily asymptomatic bacteria. And they made a really good point to recognize that just altered mental status cannot count as your only symptom of a UTI. So, in order to be counted as a symptomatic UTI, patients have to have either a fever, rigors, new onset hypotension without an alternative cause. They can have altered mental status, but it needs to be accompanied by a leukocytosis. And likewise, a leukocytosis without any sort of functional decline also wouldn't count. And then there's a couple of very urinary tract specific symptoms like suprapubic pain, CVA tenderness, potentially epididymitis or prostatitis, or pus coming out from the urinary catheter. All those would count as symptoms of the urinary tract infection. And so it's going to be a little bit labor intensive, but the idea is that collecting all this data and reporting it will inevitably help, because by adding this metric to the diagnosis of urinary tract infection, it's definitely going to prompt prescribers to think a little bit more critically about when they diagnose a UTI, because recognizing that there's going to be a little bit more accountability help around this. This also hopefully will result in a fewer number of urine cultures sent, because people are going to be more hesitant to send a urine culture in case they're going to uncover a UTI in a setting where perhaps UTI isn't high on the differential of likely things that are going on with the patient. Also, it will hopefully, by doing all this, will decrease the number of antibiotics started, and based on all of the things we've been talking about for months now, decreasing the number of antibiotics will result in a decrease in resistance and C. diff infections. So next up, I wanted to just kind of illustrate a patient case that actually we saw here up until last week. A 75-year-old male came to our hospital for an elective valve repair after he was relatively healthy when he came in, but his post-op course got complicated by an abdominal infection. So he got treated with a pretty broad-spectrum cephalosporin for his abdominal infection, but then he, in his recovery, he developed what was a questionable UTI with Pseudomonas. And here you see the susceptibilities here. It was a high colony count, but the doctor was concerned because it was Pseudomonas in his urine, so he decided to treat it. So he received a different broad-spectrum cephalosporin, which not only triggered him to have a seizure, which then triggered him to have a stroke. So as he was recovering from that, he developed a sacral decubitus ulcer, which then got colonized with the same Pseudomonas, which we found here, which has similar susceptibility, so we think it's the same Pseudomonas. And then not only did it spread to the sacrum, but it also spread to his sputum, so he fully got colonized with this Pseudomonas. And he had persistent fever since his stroke. So it was never really clear if his ulcer or his lungs were infected, because they had known colonization, plus he had these on and off fevers that could have been due to a stroke or could have been due to infection. And we never really could rule it out. He ended up getting treated again for this Pseudomonas. But eventually, with more treatment means the development of resistance, and several of our drug classes, our cephalosporins and carbapenems developed resistance, but at least he retained susceptibility. But then, a little while longer, he got diagnosed with another urinary tract infection just because he developed a little bit of altered mental status, and he had a single fever, which he had had kind of periodically since his stroke, which led to treatment, and our only option at that point was an aminoglycoside, which is pretty toxic, or Cipro. So he got treatment with Cipro, and then further cultures found that he had lost susceptibility to Cipro in his sputum, and we went on to check some novel agents, some new cephalosporin combinations that have come out in just the past few years, and it was even resistant to those. So unfortunately, care had to be withdrawn from this patient due to his dwindling overall status, and because he had no more antibiotic options left to him. And all of this was triggered by treatment of what was very possibly colonization throughout his complicated clinical course. So aside from antimicrobial stewardship, there's other ways we can prevent transmission of resistant organisms, like using precautions.
So there are a number of categories of precautions from the CDC, and hopefully many of you are aware of what they are, but we wanted to make sure that we went over them. Now, as discussed, the NHSN is going to be looking at hand hygiene data and gown glove compliance amongst long-term care facility healthcare providers. So it's important to understand when those things should be used. Now, standard precautions should be used on all patients or long-term care facility residents, and that means that all blood, body fluids, secretions, and excretions, except wet, non-intact skin and mucous membranes, may contain transmissible infectious agents. And so what is expected is hand hygiene after touching blood, body fluids, secretions, or excretions, with use of gloves, gown, mask, depending on contact and risk. So it is acceptable to take care of a patient with bare hands. If you're going to, as we say, touch something yucky, then you should be using gloves. And if your body or clothes are going to come in contact with something yucky, then you should be using a gown. And if you're going to breathe in something yucky, then you should be using a mask. So it's basically what you learned in kindergarten, and that should be applied to all patients regardless of what types of organisms you may or may not know that they have. Now, contact precautions are implemented for patients who are known or suspected to have some kind of resistant or transmissible organism. They should also be used if there's excessive wound drainage, fecal incontinence, or other discharges from the body that suggest an increased potential for extensive environmental contamination and risk of transmission. So that's really part of standard precautions. But we implement contact precautions for any contact if the patient is suspected to have something like MRSA, VRE, E. diff. And so in those patients who wear a gown and gloves for all interactions that may involve contact with the patient or potentially contaminated areas in the patient's environment. Drop-off precautions are an additional measure to prevent transmission of pathogens that are spread through close respiratory or mucous membrane contact with respiratory secretions. In patients who are on drop-off precautions, there is not a need for special air handling or ventilation. In those cases, healthcare personnel wear a mask, but not a respirator, during close contact with the infectious patient. And so drop-off precautions would be something to be implemented for influenza and certain other respiratory viruses. Airborne precautions, which we typically use for tuberculosis, but also for some other rare infections like measles, those prevent transmission of infectious agents that remain infectious over long distances when suspended in the air, and that requires special air handling with at least 12 air exchanges per hour, so special rooms, or a use of N95 respirator or mask when in public. Healthcare workers wear a mask or respirator when taking care of the patient. The patient needs to wear a mask when leaving their room. So how do you know what type of precaution to use for the specific types of infection? That information is available in the full CDC guideline, which is actually just reformatted to make it more user-friendly, and that is found at the link at the bottom of the page. It's a PDF, and it's called Appendix A, and for every type of infection, listed by organism type or even just by infection category. You will see the type of precaution and the duration for which precautions are necessary. I always find it useful to review the appropriate sequence of gowning and gloving. Sometimes surgeons look at me funny when I go over this stuff because it is different in operating rooms, protective personal equipment, when compared to gowning and gloving for isolation precautions. So this is the gowning and gloving for isolation precautions. It begins with the gown, which should fully cover the torso from neck to knees. The arm should be covered to the end of the wrist, and the gown should be wrapped around the back and fastened in the back of the neck and at the waist. The mask or respirator goes on next if it's to be used in a room where droplet precautions are necessary. The mask should be secured at the middle of the head and the neck with a flexible band at the top fitted to the bridge of the nose. The mask should fit snugly to the face and below the chin. And if a respirator is used in an N95 respirator in a TB room or airborne precaution room, that needs to be fit tested to the healthcare provider on an annual basis. Face shapes change with age, with weight gain or loss, and there may be situations in which the standard respirator or mask provided by the facility don't work for the provider, and that needs to be known. Each goggles or face shields are necessary based on the potential for aerosolizing secretions. Those go on next, over the face and eyes, and adjusted to fit. And then gloves go on last, extended to cover the wrist of the isolation gown. Now, this is really important, and citations have been issued by regulatory bodies for this. Hand hygiene needs to be performed right before hands go into that glove box. Otherwise, if you go into the glove box with dirty hands, and all of the gloves in that box are contaminated, defeating the purpose of the gloves for the patient. So when it comes to contact precautions, droplet precautions, airborne precautions, it's important to weigh the balance of the benefits of those precautions against the risk. And one of the main risks is that the time spent by the provider with the patient decreases when the patient is on precautions. And so this is just one of several studies, this one in JAMA Internal Medicine, demonstrating that the average time, in this case it was by medical interns, per visit to a patient on isolation, it was less if the patient was on isolation. And then the other downside, especially in long-term care, is in social isolation of that patient. And here's a review of CDC guidelines on contact precautions, and if you look at the third bullet there, in long-term care facilities, you need to take into account that it's important for patients to be able to, or residents who are on contact precautions, to be able to participate in group activities, and so those precautions may need to be modified somewhat to allow that to happen. We get a lot of questions about decolonization. So if a patient is known to decolonize with a multi-drug resistant organism, is there a way to decolonize them? And there are lots of studies on this, and lots of techniques have been suggested. So there is mupirocin, which can be placed inside a patient's nose to kill bacteria. There is increasing use of antiseptic or antimicrobial bathing. So we use chlorhexidine gluconate in all of our ICU patients as the mechanism of daily bathing, for example. There are strategies in which oral antibiotics are used to decolonize patients, and there are studies where gastric lavages are done with antimicrobials. And some of these can be useful in outbreak settings, and certainly pre-procedure, many of these techniques have been shown to be beneficial. So a combination of mupirocin in the nose and chlorhexidine bathing is the standard in high-risk operative procedures pre-op. And we do that for our patients at Tufts Medical Center before certain types of surgery. But the benefit of that is not durable, and it's not as good as a management strategy. You can do intranasal mupirocin, you can do chlorhexidine bathing, you can use oral antibiotics, and you will see a temporary decrease of multi-drug resistant organism colonization. If that patient remains in the same setting, then re-exposure from the environment is likely. They may become easily recolonized if their susceptibility to that stays the same. And in fact, there are concerns, certainly if antibiotics are used for decolonization, there's a high risk for resistance to antibiotics, but there are also concerns for development of resistance to some of the antiseptic measures. Mupirocin resistance has been demonstrated, where Hygiene resistance is increasingly being questioned. So in summary, there are reportable metrics that will be required for long-term care facilities in the near future. C. diff will be the first one. Others will likely follow soon after. It is a challenge, but we think a worthy battle to limit transmission of organisms between nursing home residents. Antimicrobial stewardship is a key piece of preventing transmission of multi-drug-resistant organisms, in addition to other strategies which we have discussed. So that takes us to our last polling question. This is a question that we have used at the end of each of our other webinars, and we'd like to see what people think. I feel that the strategies discussed in today's webinar are, and please open the polling, largely feasible in my facility, not feasible in my facility, and or already being used in my facility. I hope that we've given you some new strategies today, but mostly I know that we have given you a taste of what's to come. I hope that you will take the time to think about some of the things that are coming and how you're going to begin reporting some of these measures in the future, thinking about hand hygiene and observations perhaps, thinking about gowning and gloving and standardizing practices so that you can report those measures to the CDC in the future. The polling has closed. And we'll see soon how feasible people think these things are. It is daunting, I know. I feel daunted just thinking about all of those measures. But the hope is that they will improve practice and result in decreasing hospital-acquired infection rates as they have in the acute care setting, where we report some of those same measures to CDC, but not all of them. So we do not report our hand hygiene rates or our gowning and gloving compliance, although we do measure them we do not report them within the NHSN mechanism. In the acute care setting, we report C. diff and UTI and central line-associated bloodstream infection and hospital-acquired MRSA bloodstream infection. So we will take a look at those results momentarily. And while we wait for that, I will pass the ball back to Lacey.
Awesome. Thank you, everyone. Did the results come up for the polling? Did you get that?
They're not up yet.
Oh, okay. Well, while we wait for that, thank you for a great discussion. I just wanted to, I know we're 3 minutes past, and I just wanted to see if maybe you all have some questions. We can open up the lines now for some questions. You can press #6 to ask a question, or you can pose your question on the chat box.
So the polling results came back, and pretty much everybody said that the strategies were either feasible or already being done. So that's fantastic news.
Awesome. Do we have any questions?
Alicia, it looks like there's a couple in chat.
Oh,
Go right ahead. Hi, this is Janet from the Providence office of the New England QIN-QIO. Thank you for that very, very thorough presentation. I just wanted to mention a couple of things. When you talked about the CDI reporting into NHSN, I just wanted to make sure that the listeners understand that although it is laboratory data that is being reported, the lab does not report the data. It is still on the onus of the nursing facility to actually report those positive tests, because I felt there was a section where that wasn't clear, that it is the lab will not report to NHSN. The nursing home must do that. And I also wanted to mention, when you're talking about strategies for Clostridium difficile, I have found in my consulting experience that the use of commode liners when a resident has active C. diff really can cut down on environmental contamination. And there are a couple of companies, they actually also make products that will fit into a bedpan or actually even into the toilet. It certainly does not reduce the need for hand hygiene, but it can reduce the level of environmental contamination. So I just wanted to mention that the use of those liners can be very helpful when someone has active diarrhea.
Thank you for those two comments. That was really useful. Thank you. Other questions or comments?
Hello?
Yes.
Hi, my name is Bruce Knapp. I'm calling from Connecticut, and I wanted to let you know that our facility is one facility that did jump on board with NHSN to voluntarily help report the CDI transmissions. And I am so glad that we did it because the site is not easy to navigate. So if and when it becomes mandatory, if the listeners have the opportunity to jump in now, even though we're like halfway through the year of the voluntary year, it would be wise, because there are going to be cutoff dates, and I was told by one of the people at NHSN that when it does become mandatory, that they're looking at a 2% infraction fee based upon Medicare income as the penalty for not having the work done on time. And if you have no experience with it, there is no way you're going to get it done on time. It's that complicated.
Yeah, we agree that, and I tried to show you as many examples as we can without spending the entire time really getting into the nitty-gritty, but I agree that it is a complicated process. The forms are complicated. There are instructions on the website, but even still, experience is really the best way.
Right.
So we really encourage during this voluntary period, just get yourself familiar with it. And the benefit is that you have, the more you report, the more benchmarking data you have for yourself. It's only for your own self-improvement.
Well, the thing is, there's going to be a specific data. Right now, it's the 25th of the month. And for somebody who thinks, oh, I only have 2 people who had C. diff this month, or even if you had 0, it is a very timely process to get your zeros in there. Anyway, that's all. Thank you.
Thank you. We have a question in the chat about contact precautions for residents or patients who are colonized with MRSA in their nares, in their nose, and whether that should be droplet precautions because it's in the respiratory tract. The issue of droplet precautions for nasal colonization or respiratory colonization is pretty confusing. I think it's something that is relatively unclear in the guidelines. Most hospitals, acute care facilities, would not use droplet precautions for nasal colonization, but might implement droplet precautions if a patient known to be nasally colonized by MRSA develops a productive cough. Although you will see many patients with MRSA and productive coughs who are not on droplet precautions. Droplet precautions by the CDC guidelines are really recommended mainly for viruses. We have a question: if a patient has not met criteria for ordering your urine, but a PCP orders and the results show greater than 100,000, how does that count in infection rate? So what I would say is, if the patient has not met criteria from a clinical standpoint, if the patient doesn't have criteria to have a UTI, so if they have asymptomatic bacteriuria regardless of the colony count, then that patient does not need treatment. But the treatment is not really going to factor into whether they're going to be an NHSN reportable condition. NHSN, as Shira mentioned, is looking for symptomatic UTIs, and the only situation in which an asymptomatic patient will be counted as having a UTI is if that organism that's grown in the urine also grows in blood. So that's the only situation in which someone who essentially didn't meet criteria for ordering that urine is going to count as having a UTI. Now, if the patient has no symptoms and they have an organism in their blood and in their urine, no symptoms of UTI, then the question in my mind becomes, how did that organism get into their urine? Is it really a UTI, or did it get there by hematogenous spread, right? Did it start in the urine, in the blood, and then go into their urine? Or do they happen to be colonized in their bladder by that organism, but the source of infection is something else? And so again, I would say, do not order a urine if the patient doesn't have convincing signs and symptoms that suggest a UTI, even if you might be ordering a blood culture. And that this idea of a pan culture for fever, so culturing every site imaginable in every patient or resident with a fever, really needs to be addressed, because a pan culture is not consistent with good antimicrobial stewardship, because inevitably a pan culture leads to finding something that's positive because of the high rate of colonization and overtreatment.
Great. Well, thank you all for the great discussion. If your question was not addressed, I have the Contact Your Nursing Home CDI initiative. Say contact on the screen. You can definitely send your questions onto there, and then we'll definitely address those questions and send out the responses on our follow-up email. So that's pretty much it. Thank you all for attending, and have a great day.